So the slightly less expensive version of MRI is the dual energy X-ray absorptiometry, or DEXA. So this is a three-compartment model where we have fat-free mass, fat mass, and bone mineral density. We can get whole body and regional estimates. So if we look, let me get my pencil ready. If we look down here, we can see that it will give us the regional percent fat. It'll give us the bone mineral content, fat tissue, lean tissue, total tissue. It's non-invasive, but it does involve radiation, which may not be good for children. So now let's look at our field methods. Again, these are usually easier and cheaper. So the first is bioelectric impedance, or you'll sometimes see BIE. This is a weak electric current that goes through the body and measures resistance. So think about the last time maybe you were at a swimming pool, it was lightning out, everyone has to get out of the swimming pool. That's because water conducts electricity. This is electricity, little lightning bolt. So from that, we can calculate body fat. It's relatively inexpensive, especially compared to an MRI. It can be fairly portable. However, there are some important sources of error. So we know that H2O conducts electricity. Fat does not conduct electricity. But skin temperature will change the resistance. So H2O conducts electricity. We say it has low resistance. Fat does not conduct electricity. It has high resistance. So when we have a cold skin temperature, like when it's very common in Laramie, this will increase electrical resistance and it will overestimate body fat. Whereas if we hop down to Texas or something, or even Denver these days, increased skin temperature is related to decreased resistance, and it'll decrease the estimate of body fat. Additionally, hydration status. So if we're dehydrated and we have less H2O, so dehydrated, less H2O, which means there's less water to conduct the electricity, which means increased resistance. Now we can also overhydrate ourselves and artificially increase how much water is in our body, and that will decrease resistance, and that will make it look like we have lower body fat. It also tends to overestimate fat in lean people and underestimate fat in people with obesity, and it's not appropriate in clinical situations. So again, fat mass is a non-conductor. Fat-free mass is a conductor. So we can take our known weight of the body, and then we can subtract some amount of fat-free mass. We don't know what it is yet. But if we subtract the fat-free mass, we'll be left with fat mass. So we know that on average, total body water is we're about 73% water. So we can take the fat-free mass and multiply it by 0.73 to get total body water. Then, if we know the total body water, based on how much our fat-free mass is, we should be able to know about what the resistance would be. So any resistance that is less than that would mean that there was more fat-free mass, and if the resistance is increased, it means there's less fat-free mass. So there's a couple of different ways we can even use biological impedance. The first is a single frequency, and it's not valid for significantly altered hydration status. There's also multiple frequency. Because a wide range of potential frequencies have been suggested, the multiple frequency is generally more accurate. So you've probably seen the little scales that you step on. They have like silver foot pads. What this is doing is it's sending the electrical current all the way through the body and then measuring it at the other side. This is called foot to foot. There's also hand to foot, in which an electrode is on the hand and the electrical current is measured through half of the body. This is hand to foot. There's also hand to hand, but the hand to hand is the least accurate. This has really only been validated in white populations, and it is not valid in pediatric populations. So waist circumference and waist to hip ratio are also very useful field methods that are easy to train and inexpensive. So risk for diabetes, dyslipidemia, hypertension, cardiovascular disease increases with abdominal obesity. And we're indicating that as a waist greater than 40 inches in men and greater than 35 inches in women. The theory behind this is we know that body fat accumulation around the abdomen is the type associated with our cardiovascular outcomes. And so there's several different methods. We're going to use the NIH method, but I just want you to be aware that when you're reading papers, it's important to see which method they're using. Unfortunately, waist circumference and waist to hip ratio aren't as useful in people with without obesity class 2. But you know this probably because of the ABSI score. The ABSI score was the most useful in people with obesity class 2 and people who are underweight. Although, because we know that individuals of East Asian descent are at a greater risk at a lower BMI, it is a better predictor of disease risk in people with East Asian descent. Waist to hip ratio can further deduce gynoid versus android fat composition. And a high waist to hip ratio, meaning your waist is much bigger than your hip, is associated with an increased risk of cardiovascular disease. So now we'll move on to the calipers or skin folds. Here you'll use a skin fold that looks a lot like this one in lab. This requires a lot of training, so you're going to get a lot of practice. It can be uncomfortable. People don't like getting pinched. It's important to note that only subcutaneous fat is measured. You can't pinch fat. It's practical if a private area is available, and when you get trained, it takes about 5 minutes. It'll take longer before that. So there's two main types of calipers used, Lang and Herpenden. There's no statistical difference between the types of calipers, although I would be wary of the type that are just plastic that you might get handed out at like a conference or something. And previous research has shown there's no difference between the left and right side, even in the body of tennis players. But you should always measure on the same side. And we'll go through this more in the lab. Overall, SkinFold shows good reliability in estimating total body fat. Error increases in lean subjects in older adults. Think about older adults' skin, and ideally we'll get some older adults to come to the lab, but the skin becomes less turgid, it pulls away a little bit easier, you might not get as good of a pinch, but also think about how fat distribution changes as you age. So as a rule of thumb, each kilogram of subcutaneous adipose tissue is associated with around 200 grams of internal adipose tissue. Of course, this is just an estimate. So these are the assumptions. The double thickness of skin and adipose tissue has a constant compressibility. Mostly this is true, but not always. Skin thickness is negligible and a constant fraction of the skin fold. Again, mostly, but think about if there's calluses or psoriasis. Ugh, psoriasis is hard to spell. Thickness of subcutaneous adipose tissue is constant or predictable within and between individuals. This is, again, mostly true, but could be different. The fat content of adipose tissue is constant. We have to assume that the proportion of internal to external fat is constant, not always true. And that body fat is normally distributed. And by this, not normally in the body, but normally as in a bell curve. So when pinching people, how many pinches? A minimum of 3 sites is recommended. A 2 site has been validated for young people, and a 1 site was developed for large epidemiological studies. And this is the triceps skin fold, and we'll talk a lot more about that. The 7 site is probably the most accurate. It can include chest, mid-axillary, triceps, subscapular, abdomen, suprailiac, and thigh. So we use standardized formulas to derive body density and body fat from caliper recordings. There's different equations based on biological sex. This is a good quiz question. So why do you think that there's different equations based on biological sex? Think about where fat is distributed on men and women and why we would want to measure different areas. We then use estimates from regression analysis of sum of skin folds at specific sites. We may also just use the sum of skin fold thickness. The sum of skin folds shows change without error in the conversion of body fat percentage. So these are just 2 different ways of deriving the same thing, which is body density. So the 2 methods: regression equation to predict body fat from subcutaneous fat stores are skin fold sites, using the sum of skin folds. And so the typical sites for a man are the chest, abdomen, and thigh. Think about android versus gynoid fat distribution and why we measure chest, abdomen, and thigh in males, but triceps, suprailiac, and thigh in females. So, really important, the equation, the population, and the sites measured have to match, and they have to be validated. You cannot mix and match. No, mix and match. The measurement sites have to be the same as recommended in the equation. The equation has to be validated in the population you measured. So if it's not valid for children, you can't use it for children, even if it's validated for adults. And when possible, use the same family of equations in your practice, as this allows for comparisons between individuals. If that isn't possible, try to use the same equation within person so that you can check over time. And you must use standard sites, even if they're kind of uncomfortable. So the triceps skin fold was the one I mentioned that a single measurement was developed for use in large epidemiological studies. So this is used with mid-arm circumference to estimate nutrition status, and there are standards available. It's used with other skin fold sites to estimate body fat. The technique is important. You're going to take the midpoint between the acromion process, which is the shoulder, to the olecranon process, the elbow. So if an arm, here's my little hand, that would be the upper shoulder to the elbow, and then you're going to take the halfway point and then measure the circumference. And we'll go over this more in lab. And it's best when it's monitored by the same healthcare practitioner over time. It can be affected by hydration, edema, exercise, and most importantly, the technique of the person measuring it. So now that we know how to measure body composition, how do we analyze it? In a hospital setting, you won't do a lot of body composition. Usually in a hospital setting, things are happening too fast to ask someone to get a DEXA scan. Keep in mind that different methods can give different results. Skin folds can have different results based on the equations, the sites of the skin folds, the circumferences. These, though, you're more likely to see in a clinical setting, especially the tricep skin fold. Less in clinical settings, but more in commercial settings, so like a gym. You'll see bioelectric impedance. Some fancy gyms now are even getting a bod pod and a DEXA. Hydrostatic weighing, CT, and MRI, you'll really only see in research settings. These are much too intensive, even for the fanciest gym. So important considerations when estimating body fat. Body fat is not measured directly. We can't just go in and scoop all the fat out, put it on a scale, and then scoop it back into the person. So all methods have inherent error. Technicians and subjects can add more error. So when I was trying to measure body fat in toddlers using MRI, the subjects kept wiggling or crying or just moving around like 4-year-olds will, and that increased my error a lot. So I've been mentioning the standard error of the estimate, or SEE. If the SEE is 2.7, it means that 2/3 of people will have a body composition within 2.7%. But 1/3 will have a body composition outside that range. So again, remember our bell curve. For a majority of the people, the error will be pretty minimal, around 2.7%. But out here, it could be larger or smaller. This out here, where I have these red lines, is 1/3 of the population. 2/3 are under this bell curve between the pink lines. So how can we minimize error when estimating body fat? Training, training, training. That's what lab's for. You can always try a different equation, but you can't get new data. Always take multiple measurements. Rule of thumb is at least 3 measurements. Take the mean of those measurements. If a measurement is different from the mean by a standard deviation, redo that measurement. Choose the method and the equation validated for the population. So equations to estimate body density. We have the Duren and Wormsley, Jackson and Pollock, and it depends on how many sites you want to measure. So these are for body density. For body fat, we need to take our equation from body density and either use the Siri or the Brozic. And this is going to give us our percent body fat. And again, has to be validated within the population of interest. So the Siri tends to overestimate body fat in older adults. The Brozic is a little better for older adults. The Brozic has a Caveat that it works best when also using the Duren and Wormsley equation. So Broszek and Durham and Wormsley should be used together. But how much body fat is quote unquote normal? Well, like I mentioned earlier, this is a difficult question. We have a rough idea of essential body fat. This is the amount of body fat we need to stay alive and maintain reproductive success. The average amount of fat may not be ideal, but we really don't know. And lower is not always better, particularly for women. Low body fat is related to low bone density. Body fat equals low bone mineral content. And it can also, low body fat can lead to cardiovascular problems. So there are no body fat standards or widely accepted cutoffs for percent body fat. These are a couple of random body fat cutoffs, but again, we don't have any standards. A person's weight history and weight pattern is much more important than any single measurement. Just because someone has obesity doesn't mean that they aren't malnourished. A patient can be normal weight, overweight, or obese and have malnourishment. The most important is the change over a time period. That's how we're going to assess significant and severe weight loss. So if a person loses 1 to 2% of their body weight in 1 week, that's significant weight loss. Greater than 2% of their body fat, or not body fat, body weight, is severe. This is bad. Severe is not good. And again, we see that it increases for 1 month, 5 weeks, 3 months, 7.5, 6 months, 10%. All right, that's it for now. Thanks for listening.